it's good with everyone else, I'll get going because when I did a dry run, this clocked in about 55 minutes. So um, thanks for everyone for coming in. If you recall, I was supposed to give a grand rounds in February, but on the day I was going to present, I literally had no voice. So I couldn't really talk so much, probably for the benefit of everyone else, but couldn't really give a lecture. So in that regard, I was going to talk about ANCA in anticipation of a visiting professorship, but since the professorship came and went, I don't need to talk about ANCA anymore. So I'm going to do just a update of what has come out in the last 12 to 18 months involving glomerular disease. And as I, Isaac was talking about, there's been a lot of development that's been very, very impressive and very, very exciting. The notion that we're in a glomerular disease renaissance is really remarkable. And a lot of what I'm going to be talking about are actually phase 3 trials, which is great to see. So to start things off, gotta do the disclosures. So I'm equally conflicted with a lot of these companies involving clinical trials and advisory boards. But in that sense, it just lets me see their data before they publish it, which was very helpful. I'm not going to talk about anything that's not published, so it's all what's publicly available data. Alphabetically going to start with ANCA. And the big thing with this one actually involves what's come out of the FDA involving the drug avacopan. So most of us probably already heard that in January 2026, the FDA actually approached Chemokinetics and its parent company Amgen and asked them to voluntarily withdraw avacopan from the market. They said it was due to liver injury, but they didn't really come out with much until just last month, where they posted what they saw on the FDA side, that 76 cases of DILI occurred with avacopan. The vast majority of these were 66 cases that occurred in Japan, 5 were in the US, and 1 was in Canada. 74 of these were considered serious, which include 54 hospitalizations and 8 deaths attributed to liver injury from avacopan. The majority of these were cholestatic injury or a mixed pattern of injury, and 7 of these 76 cases had biopsies that showed vanishing bile duct syndrome as the complication of the DILI. I honestly don't know much more beyond that for what vanishing bile duct syndrome is, but that's what they saw in the biopsy. The median time to onset of this was about 46 days. So after negotiating with Amgen and Chemokinetics, the FDA is allowing them to continue on the market with the recommendation that you monitor LFTs before you start therapy, 2 weeks after starting, and then every month for the first 6 months of therapy, and then as indicated. And if you see an increase in your ALT or AST greater than 3 times upper limit of normal, or an alkaline phosphatase greater than 2 times upper limit of normal, you're supposed to do a hard stop of the avacopan and report it to the FDA. I would suggest that if you are seeing a rise in LFTs, that you generally just stop it and probably report it to the FDA as well. They do have a website telling you how to actually report this adverse effect. So this is a little bit of a pause in the sense that we were very excited to see avacopan come out as a new steroid-sparing agent, but I'd like to remind everyone kind of what the data showed and remind everyone that when this drug actually first went up for approval, the FDA was actually very hesitant even before we found out about this liver injury of getting it approved because of what their main study, the Advocate trial, showed. So I'll briefly go over that just so we can better weigh the risks and benefits of what this drug could potentially do. So this is the Advocate trial, initially published back in 2021, where it compared avacopan to prednisone. So if you recall, when they first published their data, 75 and 82% of people who entered the study, so even before randomization, were already on steroids. And they reported initially about 650 milligrams and 720 milligrams as the how much prednisone they had before they even got randomized. They actually came out in 2024 with a addendum to that, saying that they miscalculated the actual prednisone dose equivalency. So they actually both end up getting closer to a gram plus minus another gram before even entering the trial. So that's actually what the FDA was a little concerned about, is that when this drug first came to market, a lot of people were saying this is going to be a steroid-sparing agent. And the FDA said, well, actually, no, this is not a steroid It is steroid sparing, but they still need steroids up front. So you can't necessarily not give steroids when using this drug. And then what we don't talk about very often is actually during the trial, 20 more patients in the avacopan arm actually got started on steroids. And if you look at the total cumulative dose of steroids, it was close to 2 grams after this initial gram already. So they're already getting like 2, maybe 3 or 4 grams of steroids, and that's in the avacopan arm. Certainly, it is less than what the prednisone arm got, but it's still a fair bit of steroids. And the other thing to point out is how long the arms were continued. So prednisone, if you were in the prednisone arm, you stopped prednisone at 21 weeks, as opposed to avacopan, you continued for 52 weeks. And that's important when you look at the outcomes, because initially it was non-inferior to prednisone at 26 weeks when it was a true prednisone to avacopan comparison. But when you get to that 52-week mark where it's really avacopan versus nothing, that's when avacopan wins. And so, in that sense, that is avacopan better than nothing? Absolutely. But is it necessarily better than prednisone if you continue it for 52 weeks? I'm not 100% sure on that, based on how the trial was designed. And
Jamie, oh, I'm
yes,
sorry.
go
I
ahead.
was going to ask if I can interrupt with one comment, one question. The comment is it's almost shocking to me that they didn't protocolize steroid taper for this trial. If the whole purpose is non-inferiority, it's just very surprising. That notwithstanding, my question is this DILI, what is the incidence rate? Are we talking about 10%, 0.1%?
So the initial study, when they talked about liver injury, they reported about 9 cases. It wasn't necessarily DILI itself. The overall incidence is not well known because this is after market reports, so we don't know how many people truly got exposed to the drug that developed it. But it's probably somewhere closer to that 1 or 0.1%. But if I tell a patient 1 out of every 100 patients I give this drug, you're going to die from a liver complication, that's a very serious side effect.
Yeah.
So um, it, I'd like to bring this up as well. We talk about avacopan being a steroid-sparing agent, and that we can get away with less steroids in that regard. I want to just bring to everyone's attention that since Pexavas came out in 2020, there've actually been a couple other groups that have published studies using even less steroids than the low-dose Pexavas taper has been initially reported. There's probably half a dozen different protocols out here. I'm only going to show you the UK memberness or the UK cohort and this study out of Japan called LOVAS, where essentially they gave no pulse steroids at all and only did oral steroids and compared their outcomes. And all these ones say that if you use less steroids than avacopan, it's no worse of an outcome than using what we use classically high. So if you compare apples to apples, what patients were enrolled in these studies? So Pexavas, if you recall, was a fairly sick population with a lot of people on dialysis. Advocate did not include those patients in their trial. They excluded even the ones on dialysis. Most of them had relatively preserved GFRs. They were relatively healthier populations. NPO lets us know specifically because this is the type of disease that tends to manifest more renally. So these individuals are more likely to be renal patients. So relatively comparable in that sense. But if you do total dose of the steroids for the avacopan arm versus total dose for the Pexavas low arm, you get about the same or pretty close. And then if you actually do a comparative study for avacopan where you look at truly excluding anyone with severe renal disease who are on dialysis, maybe a slightly older population, if you believe the low-VAS data, you can get away with even less steroids than what the people in the avacopan arm got. So while I don't want to be a complete naysayer in the sense I do think avacopan can help, particularly those individuals who are having complications from steroids, who may not be able to tolerate it either because of osteoporotic or mental health or obesity related things or glycemic control. But it does give me more pause knowing that what the data initially showed that steroids are by all means not good, but avacopan has its own bag of complications, and you need to weigh those against the potential risks and benefits. So moving on, in talking about complement, C3G, well, fortunately, we don't see this disease very much. It is something that has been kind of an orphan disease that we didn't have a lot of treatments for. We would throw some steroids and MMF at it, some ACE and ARBs, and hope it would just get better. But now in the last 18 months, we actually now have two FDA-approved drugs for this. And the first one that came out was iptacopan, which is the oral factor B inhibitor. This blocks the alternative complement system. And they were able to show that if you give iptacopan for 6 months, that you can reduce the amount of proteinuria in these individuals by 30%, with a difference of about 37% for those who didn't get iptacopan. And they had a slight improvement with the iptacopan in their GFRs that maintained while on therapy. And if you gave the iptacopan to the people that were in the placebo arm, they actually got a little bump in their creatinine or GFR as well. So everything looked pretty good in the sense of it does seem to reduce proteinuria and stabilize GFR. How was the safety side effect profile? Everyone gets worried about the complement inhibitors having a lot of safety adverse effects. Overall, it was actually fairly well tolerated. Most of the adverse effects were relatively mild. Now, if you compare the iptacopan to the placebo arm, where there are a little bit more serious adverse effects, yes, they were more moderate and severe. But overall, still the incidence of adverse effects were pretty low. How about the risk of infections or serious adverse effects? There was one streptococcal pneumonia bacteremia that happened in the iptacopan arm. There was a worse infected bite that happened in the iptacopan arm. But overall, pretty decent safety side effect profile given the concerns that come with complement inhibition. Now, it's important to remember with iptacopan that you do need to enroll them in REMS. You do need to have them vaccinated against meningococcal and pneumococcal with an option to revaccinate them against Haemophilus. In this trial, they did have everyone on prophylaxis for the duration of the trial against meningococcal disease. So getting a pneumococcal bacteremia despite prophylaxis is maybe something you definitely have to keep an eye out for. And you do need to provide these patients with a complement medical card that they carry with them at all times in the event that they get hospitalized or found obtunded that they need to be ruled out for meningitis, because it is a safety concern. But we also have this new drug, pegcetacoplan, I think I said that correctly, that came out a couple months after iptacopan reported their C3 data. And this one is a C3 and C3b inhibitor. It binds the receptors. And they showed in their trial that they can reduce their proteinuria in C3 patients by 67% with a stabilization in their GFR as well. So overall, very promising results. So how is it given? It's actually this interesting little device where the patients are actually given vials of the pegcetacoplan and then actually loaded onto this disposable infusion injector where you load it and this little red indicator fills up. The patient applies it to their abdomen and pushes the start button on their egg timer that will inject the drug subcutaneously and infusion over 30 to 60 minutes. And after they complete the infusion, this little timer pops out. The patient can now then disconnect it from their body and dispose of it and then redose later that week. How was it safety side effect profile? Very, very good in the sense they were actually very comparable, no increased risk of serious adverse effects compared to the placebo. And actually, there were no serious injection-related effects reported with this drug. So it overall looks very good. Similarly, this is a REMS program that you have to enroll them in because it's a complement inhibitor. You do have to vaccinate them against meningococcal and streptococcal and give them prophylactic antibiotics, and they have to carry the same medical card saying, I'm on a complement inhibitor. If you find me down, please do an LP on me. So overall, very good. But if you have a patient in front of you, right, what am I going to do with a C3 patient? So I would like to put these side by side and give you kind of a comparison on when one may be better than the other. Okay, so if you look at how they work, certainly some of us think, maybe Dr. Thurman thinks of, I want to block the alternative pathway more than the common way, but this is not necessarily something I think about all the time. But one big important thing is, do I think my patient can take a pill twice a day, or do I think they can do these infusions at home where they're going to have to load up this little egg timer and inject themselves? So that's one big thing for me. Who was included in the study? So iptacopan only did adult patients. So they had to be over 18 and less than 60 with an average age of around 27. Pegcetacoplan actually had more than 50% were adults, but they included a fair number of adolescent patients as well. How long had they had the diagnosis? Iptacopan, over about two-thirds of them had a diagnosis for over 2 years, meaning they probably had some chronic damage already on their biopsy before they enrolled. So maybe that's why there was less proteinuria response. As opposed to pegcetacoplan, if you were adult, you had to have a diagnosis within 6 months or less to qualify for this trial. So pegcetacoplan is more of a new diagnosis, active disease kind of thing with relatively minimal chronicity to it. Could I be on it if I got a transplant already? So if I've already had my kidneys fail and now I'm post-transplant with the recurrent C3G, can I be on this trial? If you're in iptacopan, no, you could not. But if you were you could enroll in the pegcetacoplan drug. So similarly, how many people were on concurrent immunosuppression, whether it be prednisone or MMF? So more in the pegcetacoplan, partially because some of them were already status post-transplant. We've already kind of talked about, what the GFR and baseline proteinuria reduction and everything is. So it really comes down to for pegcetacoplan, if you have someone with a new diagnosis, I think that's where the data would suggest that drug may be superior. If someone is already established, or maybe you're concerned about a flare, maybe iptacopan would be a better choice. But they're not exactly comparable, the same in my mind, because they use slightly different study populations. Any questions about that before I move on to FSGS, another kind of orphan area?
No, Jamie, clear.
All right. So I bring up FSGS, and I'm going to talk mainly about this radar data because this is a change, particularly at the FDA level, and it's going to be changing how drugs are going to be evaluated in the future. So if you guys recognize the lead author, David Pitcher, he's the lead author who did the UK radar data for IgA that made a big splash and helped change how we approach IgA therapies. Well, it's happening now for FSGS. So what they did was take the UK cohort and looked at outcomes in patients with FSGS and minimal change. So they saw that people with minimal change actually had a fairly good overall 10-year outcome. And then you had this uncertain population where they were said to have FSGS, but it wasn't clear exactly what the etiology of the FSGS was, so it was relatively poor documented. But they had good outcomes. But if you looked at FSGS that was believed to be immunologic, so kind of this acute onset recurrence after transplant type, or those who had a biopsy initially showing minimal change that on repeat biopsy was FSGS, or a genetic cause for FSGS, they found that those individuals had worse outcomes than the minimal change. So they then went down into a smaller population and said, at what point, if we could say proteinuria reduction provides a benefit? So these are all the FSGS patients with either genetic or minimal change to FSGS or immunologic FSGS. If we can reduce their proteinuria to what level at 6 to 12 months, is that a clinical meaningful outcome? And they showed or found that if you could get their proteinuria to less than 1.5 grams by 6 to 12 months, those individuals tended to have a better renal prognosis at 10 years, or really at 2 years, than if you, say, allowed them to be about 1.7. And then they risk stratified all this thing based on age group and what their baseline GFR was and proteinuria, and said that really, if we can get proteinuria down to 1.5 grams or less in FSGS patients, that's a good clinical outcome, and that's going to be protective for them long term. And I bring this all up because most of you may have known that just a couple of weeks ago, the FDA actually approved the very first FSGS drug. And that's in the drug Filspari or sparsentan, for those who know it from IgA. That is actually based upon a trial that was from 3 years ago. And when this came out 3 years ago, it was kind of a nothing sandwich in the sense that when it was reported, uh, a lot of people were like, well, that was disappointing because their primary outcome was actually just looking at partial remission of proteinuria, getting it down to that 1.5 grams or less uh, in a 6 month time point, and with a greater than 40% reduction. So initially, while it did reduce the proteinuria, it did not preserve GFR at a year, or 2 years actually. So when this came out, everyone was like, "Yeah, it's great at reducing proteinuria, but doesn't save any kidneys." Um, but now that they have this data out there saying that maybe proteinuria is going to save kidneys at 10 years, but maybe not save kidneys at 2 years, we can use this as a pathway to approve drugs. So in that sense, this is going to be a paradigm shift. There's going to be a bunch of FSGS trials coming out now that are going to be using endpoints similar to IgA in the sense they're going to be targeting a protein reduction of 1.5 or getting proteinuria down to 1.5 or less, but within the first 6 to 12 months. And if they can hit that endpoint, the drug is going to be probably approved through the FDA. And then they're going to just collect GFR data for 2, 3, 4 years out before they give them the full approval. So in that sense, there's going to probably be a flood of FSGS trials and drugs coming out here soon. Whether this is going to lead to clinical meaningful outcomes is yet to be determined. Certainly, it's different in a retrospective cohort report that we can actually prospectively improve outcomes. But this is where the FDA is going to kind of be pivoting to try to get more drug discovery in this space. So that's why I wanted to bring this up a little bit. So as of today, there's no new outcomes in FSGS or that, but we do have a drug now that's been FDA approved for it. Whether you can get the insurance companies to pay for it or not is another matter, but that is available. But, since sparsentan got its initial approval with IgA, let's talk about that since it is probably the most active space, as most of you know, that it seems like every other week or so, there's a new drug that got approval or has a positive outcome. So just to briefly review, the 4-hit hypothesis for IgA, where something happens in the terminal ileum of your gut that causes your immune cells to respond, particularly antigen-presenting cells and activating naive T cells or naive B cells that lead to production of galactose-deficient IgA, which enters the systemic circulation. That's hit 1. And then hit 2 is you develop an autoantibody to this galactose-deficient IgA. And hit 3 is when they meet up and start rumbling and form immunocomplexes. That's hit 3. And then when that deposits in the kidney causing inflammation, that's hit 4. So when I talk about all these drugs, I'm going to start by actually putting up front where we think they actually work. Because if you're thinking of where the disease is most active, you can kind of try to target where you think these therapies have the best implication. So I'll start off with atrasentan, mainly because it begins with A, and it was closest thing to sparsentan that has been recently approved on the expedited pathway. So early 2025, atrasentan came out. It's the endothelin A receptor, very similar to sparsentan, except this does not include the ARB portion. And they found that they had a 38% reduction in proteinuria in these individuals. Safety side effect profile was pretty similar compared to placebo. Important differences, though, I would point out is muscle spasms. They noticed, at least in atrasentan, more individuals reported muscle spasms. Not so much in the peripheral edema, but also anemia, which was a little surprising since the other endothelin A receptors, at least the very selective ones, had not as much of a signal. But in this one, particularly, they found more of a signal for anemia occurring in about 8% of patients. So another endothelin receptor antagonist that's available in our quiver. How does this compare to sparsentan? So the benefit of atrasentan is it doesn't have a REMS program, as opposed to sparsentan, when you have to enroll them in a REMS program, say you're going to monitor their liver function test every 3 months. Atrasentan actually doesn't carry that same requirement. They are recommending that you are monitoring liver function tests in patients on atrasentan, but not to the same degree of requirement as sparsentan. Um, it doesn't come coupled with the ARB in the same pill, which is great for individuals who may not be able to tolerate a max dose ACE or ARB. So if you have a patient who can only tolerate maybe 10 or 20 milligrams of lisinopril, trying to switch them to sparsentan, where they're going to get the full 300 milligrams of irbesartan to get onto the max dose of sparsentan may not be the right choice for them. But you could use atrasentan and keep them on the same dose of ACE that they can tolerate. In that vein, they had less hypotension reported with the atrasentan thing, maybe because it doesn't come coupled with the ARB, and maybe a slight reduction in edema. Again, it's a little bit of apples to oranges in the sense they only reported 9% cases of edema as opposed to sparsentan had 14% of their population reporting edema. So maybe a little less in that regard. The cons are that you are adding an extra pill as opposed to sparsentan. It's a 2-in-1 combo pill, so you increase pill burden. Atrasentan, we don't have the 24-month GFR data, so we'll have to see what comes out there. There may be a higher risk of anemia in the atrasentan group. Again, maybe just a red herring, but at least it was reported at a higher incidence than sparsentan. And I always bring this up in IgA trials is where the patient population was mainly studied. This was a majority Asian population with only about 1 in 3 patients being from North America. I only bring that up because they have different experiences on outcomes. So as most of us may know that the Asian population, particularly in Japan, where tonsillectomy is routine for IgA, that we haven't found tonsillectomy to be beneficial in European populations or North America. They have MMF data saying it helps there. Well, it doesn't really been demonstrated to help here. And they also have more protocols for early screening, particularly in young adults, where they actually look for hematuria and proteinuria and biopsy sooner than the average practice believed to happen in Europe and North America. So the fact that it was studied in a population that may already be able to catch the disease a little earlier and have a different response based on therapies or early detection always is a little bit of a caveat for me. Moving on, iptacopan, we've already talked about it for C3. They have evidence for IgA as well. This is their 9-month data that was published in early 2025, showing that they had about a 38% reduction in proteinuria with it. I would point out that the population that they used in this was a little bit more selective than some of the other trials in the sense that they had to have a biopsy in 5 years. Most other trials allowed up to 10 years from their last biopsy. And if your GFR was less than 45, you had to have a biopsy in 2 years, and that biopsy had to make sure it didn't have, they had to be less than 50% fibrosis. So it was a very selective patient population that they chose. Also mentioned that they require vaccines for pneumococcal or meningococcal and streptococcal in this population as well. So at 9 months, you had 38% reduction in proteinuria. They just released their 24-month data showing it does slow down the rate of progression or GFR loss with the iptacopan versus placebo at about 3 mLs per year versus 7. So it does reduce your GFR loss by about 50%. The adverse side effects overall pretty mild. They did notice encapsulated bacteria infections in both the iptacopan and the placebo arm, even though both arms were on required vaccines and both arms were requiring antibiotics. They did notice about 10 infections despite prophylaxis and vaccines. So it is a ongoing safety concern and why they're in REMS. Pivoting a little bit more to newer therapies. So these are now moving into injectable agents. So these are atacicept to start. This one focuses on hit 1 and 2, where you're trying to prevent B cell proliferation and making of autoantibodies and galactose deficient IgA. This one was talked about by Ryan at a journal club earlier this year, looking that this injectable reduced proteinuria by 45%. The adverse event rate was pretty low, most of them just being injection site reactions with a little erythema, generally considered mild, without any infection complications reported. So looking pretty good for those. And then the sibeprenlimab, which is from Otsuka, that came out in the same New England Journal article looking at their 9-month data. They showed a 50% reduction in proteinuria with a very similar safety profile in the sense that there was actually no difference in adverse events compared to placebo at the 9 months, with actually no increased risk of injection reactions than just regular placebo. So both of these agents so far look very, very good and very safe. There was actually fewer serious adverse effects with the Sibi than when the placebo, so that's always reassuring. And if you don't already know, it's a race to get their drug out. There are really now 5 drugs in the market. So other than atacicept and same mechanism of action, you have teltacicept, who actually is in front of FDA right now trying to get approval. They reported a 55% reduction in urine protein at 39 weeks. We have povetacicept, which is also in front of the FDA because they had a 64% reduction in their proteinuria at 48 weeks. There's another APRIL inhibitor, so very similar to sibeprenlimab, which is the Gakibart, which is closed enrollment and will likely be releasing their data here soon. So there's all these injectable agents coming out. So how are they different, right? So there's now 5 of these agents. They all work very similar on paper. How is CB different than Ataki and all that? So it really depends upon where the B cell is and who you're trying to attack. So if you think of like rituximab and obinutuzumab, where they interact, it's generally in those who express CD20, which is earlier B cell lineage. So it's more the naive and the pre-B cell before they fully develop into plasmablasts that they target. As opposed to atacicept, teltacicept, povetacicept, these are BAFF/APRIL inhibitors in the sense they work on the same TACI receptor, and they target more of the transitional to plasmablasts. So these are B cells that maybe are getting primed by the T cells or the antigen-presenting cells, and then evolve into plasmablasts and start making antibodies. So as opposed to rituximab, these ones are already going to be existing as memory and could possibly lead to relapse. So while OB and rituximab do a great job, it doesn't target ones that have already reached adulthood, in my mind, or plasmablasts. So you're not going to actually turn off the immune response that's already been developed. Well, these ones may actually stop the differentiation and also attack the memory aspect of it. Sibi and all other APRIL inhibitors, again, is going to be a little bit later. So it's going to target mostly the memory and plasmablast cells. So those who have already have an established immune response and memory immunologic response, that's where it's going to target. So it's going to kind of come down to where you think the patient is. Do you think that the patient is somewhere earlier in their disease where maybe they may have some naive B cells that are being primed to make these antibodies? In which case, if you can use one of the TACI receptors and prevent the differentiation into memory, maybe you can prevent relapse. Or if you already think they're established, the disease has been going on for some time, you can give them an APRIL inhibitor and actually just shut off the antibody production that they already have. Maybe you're not going to stop any ongoing immunologic priming, but you can stop the disease that they have. And that's where they're going to be trying to differentiate from each other, is trying to reduce relapse, preserve GFR, and look at proteinuria. So again, trying to just kind of compare apples to apples and what drugs are out there. These are all the ones that currently have the 9-month approval based on at least 9-month data. So you can see the population, the supposed targets, where Tarpeo is more of a 1, maybe a 4, because it does have some systemic absorption, about 8 milligrams of prednisone systemically equivalent. So you are giving them a little bit of a prednisone hit, as opposed to Tacapan, Sparsentan, which are generally considered 4, hit 4 mechanisms, and then Atacicept and Sibi looking more at the 1-2. The Tarpeo, Sparsentan, Atrasentan, Iptacopan, they're all going to be orals, while Atacicept and Sibi are going to be subcutaneous injection with varying intervals. You can see the populations that they were studied. It's important to point out that these studies are starting to get pretty differentiated in vintage of diagnosis. So iptacopan, as I mentioned, had a very selective population where the average time from biopsy to randomization was a year to a little less, as opposed to atrasentan, average time was about 5.5 years. So there's a wide variation. So you have to take the diagnosis vintage into when considering therapy. GFRs, proteinuриas were all relatively comparable, but as of right now, there's a fair gap between what was initially reported from Tarpeyo, how long you give therapy for, which was only 9 months, as opposed to some of these other ones like atrasentan, where you're looking closer to 2.5 years. So there's a big difference, and you can see the proteinuria reduction. It seems like with each trial, we're getting slightly better at reducing proteinuria, which is great. However, we have not hit the apex of decrease in GFR. All the drugs that have been approved so far and had reported 24-month data, Tarpeyo, sparsentan, and iptacopan, we do see a reduction in proteinuria, which is great. And at least for Tarpeyo and iptacopan, we do see a reduction in GFR loss. Sparsentan is a little bit more complicated, but the recommendation and goal is to get their GFR loss less than 1. So we haven't quite hit that goal yet. So what we're going to need to do is start not only using our new therapies as they come out, but maybe going back and re-hacking things and combining therapies. Maybe using either an ARB or ACE, shortly followed by atrasentan or sparsentan and Tarpeyo, and then get them started on injectable where they're going to start really having the immunological benefit longer down the line, and maybe get people off of sparsentan or steroids earlier than 9 months. Maybe only use it for a couple of months and do that. This was probably the only study I found to date that looked at these combination therapies. This was teltacacep out of China. Admittedly, this is a terrible study in my opinion, in the sense that it was a weird patient population that they picked, but essentially what they ended up doing was just taking 20 people, putting them on teltacacep, and then taking 20 people and starting them on testing dose steroids, and then starting teltacacep. And they, at least in this one, showed that they could reduce proteinuria pretty dramatically by just doing the combination for a couple of months, and seeing a drop in the proteinuria sooner than if you just did the teltacacep alone. So I think this is going to be something we're going to be seeing here soon, where we're going to start using combinations, not just with ACEs and SGLT2s, but actually using immunologics in combination as well. In the vein of using combination therapies, lupus nephritis, as most of you may have already know, as Amber talked about this as in Journal Club, is we now have a new agent in our armamentarium against lupus nephritis, and that's obinutuzumab, which is the anti-CD20 agent that just reported out in March of last year, showing that at 76 weeks, interesting time point, that you can have a complete renal response in 13% more patients with obinutuzumab than standard dose MMF. They also have improved death in renal-related events at 76 months. At least that was reported, with an improvement in overall renal response. However, the big concern with obinutuzumab is the number of adverse events. They found that there was a significant number of serious adverse events reported in obinutuzumab, not quite twice as many in the obinutuzumab group compared to placebo. And it mainly stems for this infection complication in drug-related neutropenia. And as Dr. Young can attest, these individuals tend to have pretty significant hypogammaglobulinemia that can develop from this disease, in part because it is such a good B-cell depleting agent. This was republished with the same trial that at 4 weeks, 99% of patients who received the obinutuzumab had B-cell depletion below the threshold of 10. And that continued for 76 weeks in the trial, where 94% had profound and sustained B-cell depletion through the duration of the trial. If you compare that to what Lunar reported, at 52 weeks, only 79% reached the threshold of less than 20 cells. So it's a much more effective B-cell depleting agent. for better or for worse. And the question I always get, well, it's rituximab, it's obinutuzumab, it's all the same to me. But the reason why they're different is because of how they were formulated and how they act. So obinutuzumab is the type 2 and it's human, so it's a human antibody. So if you have a patient who has rituximab-related infusion reaction, they may be more tolerant of obinutuzumab. I have had some people with rituximab-related infusions that I gave OB and they did fine, but I've had some patients who also reacted to OB. So I'll put that out there. But the mechanism of how it works is because it's this modified FC portion of the antibody, it is more dependent on cellular immunity to actually deplete CD20 expressing cells. So it's going to actually use the immune system to kill off B cells, as opposed to rituximab that is more dependent upon complement, which is all well and good, but in diseases like lupus, where they already tend to be hypocomplementemic, they're maybe not going to respond as well because the antibody is not going to be as effective because there's not as much complement floating around to actually neutralize the B cells. And I just bring that up there so people know. Always trying to compare apples to apples as best as I can. These are the trials for the FDA-approved drugs in the US. I know most of us don't use voclosporin, but that is the data that we have for comparing things. So you can see that the induction regimens are somewhat comparable, though, Bliss-LN, which was belimumab, used 3 grams of steroids, or urolupus. Voclosporin or used 2 grams. OB, you could use 2 to 2.5. The disease classes are slightly different in the sense that OB did not include pure class 5 disease, which is kind of a ding against them. But if it had class 5, you're welcome to come. The proteinuria was a little less in the obinutuzumab group, but the GFRs were generally preserved. You can see the patient populations. I like obinutuzumab because it recruited a fair number of Hispanic patients, which, my patient population, that is very important representation. Looking at complete remission, so even comparing what their endpoints are, it gets a little muddy. So voclosporin reported 52-week complete remission response, while the other two did not. But if you look at overall renal response rate at 52 weeks, this is complete and partial remission. 18% in voclosporin, 8% at 50 weeks for obinutuzumab. And then Benlysta does its own thing in the sense they just reported their primary endpoint is a proteinuria less than 0.7 grams without evidence of flare. So while I put it in the category of overall renal response rate, it's technically not the same endpoint. So, but I got to have something to show, so I'm not completely biased against Benlysta. Complete response rate at 2 years, you can see 13% for both obinutuzumab and voclosporin. I would note that obinutuzumab had a 76-week time point. They didn't actually have a 104-week time point. So if you're a fan of obinutuzumab, you can say that hitting the same endpoint as voclosporin at 2 years in 76 weeks means that it works faster. I don't think you can technically go that far, but you can say it's at least comparable response rate at 2 years. Same goes for overall renal response, so complete and partial remission. It was still 13% as opposed to 19% in the voclosporin group. But the big difference in my mind between all these is, what does it have a effect on the systemic disease itself? So SLE response index, or SRI, at 52 weeks. Benlysta did have the Bliss 76 study saying 10% of patients had an improvement overall in their SRI scores, so better systemic disease features. While voclosporin actually had no difference in SLEDAI, they didn't actually report out any SRIs, so voclosporin is not going to benefit their systemic disease symptoms. While obinutuzumab had 23% of their patients in the Allegory story that was just published having improved systemic features. So while obinutuzumab, at least when you compare it, may not give you an overall better response in the lupus nephritis, if you do voclosporin versus obinutuzumab, it may help from the systemic circulation standpoint. So you have to weigh those potential benefits against each other. And that vein, most of you probably heard that just in February, obinutuzumab also had a positive study for primary membranous, PLA2R membranous specifically. This has not been published yet. They've just made the announcement saying that this drug is going to be published soon, and they're going to be moving towards the FDA to get full approval. But it looks like we'll have at least a new drug potentially out here to treat PLA2R positive membranous here soon. But we'll have to see what the safety signal is with that and how good it was compared to tacrolimus. And just because it is the age of TACI and BAFF in April, a lot of these trials, the TACI receptors and APRIL inhibitors, are actually looking in the membranous realm now. This was just one that had their published data out. Povetacicept looking at phase 2, showing that they can greatly reduce proteinuria at the 48 weeks by about 85% and deplete PLA2R antibodies within 3 months by almost 100%, at least in this small study of about 10 patients. So we may start seeing povetacicept and TACI receptors used in membranous. I will say that there is talk in some early phase 2 trials that they used these TACI receptors in lupus. And some of you may have seen data in the New England Journal looking at telitacicept in systemic lupus, specifically in lupus nephritis. Most of these companies are now taking a pause before fully exploring lupus as something to use these drugs in, but it is something in consideration. So we may be seeing those soon. And I'd just like to close just with what we have available here at the university for different trials, both interventional and observational trials. So we do have the atacicept, a rituximab plus minus Benlysta trial, the extenuation of Tarpeyo, and a complement inhibitor trial, a lot for IgA and a couple for membranous and FSGS. So if you have a patient that's potentially interested or would like to help us out with a clinical trial, we do have some available. And then we have the observational trials here where we will be taking blood and urine samples from patients. If you're a researcher who has an idea that would like clinical samples for patients with any glomerular disease, please do reach out. We're happy to share. As well as the multi-center Neptune cohort that we try to supply sample for. And they actually have a nice arm where they try to match patients based on the clinical features into glomerular disease trials. So if you have a patient with minimal change FSGS membranous who maybe would like a clinical trial, while we may not offer it here, there's someone somewhere that we can try to plug them in and find one that's personalized for them. And at that point, I will yield the rest of my time to questions.
Jamie, thank you so much. Wonderful review. I really appreciate you doing this. If I can start with a question, Jamie, going back on your slide, your very nice slide about the different drugs for lupus nephritis. So maybe this surprised me a little bit, the complete remission at 2 years is double digit, but in the low side. Do we have complete remission data at 2 years with the NIH protocol? Wasn't it close to 35-40%?
Yes. So it's close. I don't remember exactly what those numbers are. And if someone does off the top of my head, it has historically been about 30%. Whether you look at NIH, Eurolupus, or just MMF induction, it's been about 30%. And I appreciate you mentioning that because one of the reasons why this has not been that robust is they actually had a higher response rate in the control arm than they initially were thinking. If you look at the Benlysta initial complete response rate, it was only about 20%. So they had a 10% higher response rate in the control arm than they initially were predicting. They still met power, but they were a little surprised that they had as good a response in control as they did.
Thank you, Jamie. Very interesting. Any other questions? Go ahead,
Jamie,
Sarah.
Jamie, do you just want to comment on the problems with the calcineurin, though, about whether it's actually an immunologic response or not?
Well, yes. So as most of the people that have dealt with me in co-management, I don't like calcineurin inhibitors in particularly for lupus because we don't really have any data supporting that it does change immunologic response. We do have it certainly does reduce proteinuria from a podocytopathy standpoint, but if you look at biopsy data, so where they actually did a sub study in the voclosporin arm, they saw no actual improvement in immunologic or histologic cellular response with CNIs. And they actually saw it was comparable to placebo in the sense of histology. However, OB, while I haven't seen the actual publication, did have a sub-study that was presented at ASN that actually did show histological improvement at 1 year. So while voclosporin may make the proteinuria better, it may not help the immunologic response. And at least based on histological data, OB does seem to do that. I was trying to only be slightly controversial, but I appreciate you pointing that out there.
Maybe Jamie and Sarah, just a question to both of you, where you deal with these patients both at Denver Health and here at UCH. How are you managing now the class 5 lupus?
Uh, I will go first. I like well, it depends upon their tolerability for MMF. I generally like using a combination of MMF or tacrolimus, plus minus tacrolimus, and OB. If it becomes too complicated, too many side effects, then I pretty much only use the tacrolimus for making sure that they have a blood pressure so I can diurese them better, as well as just helping with the misery factor of having terrible proteinuria. But the CNI, in my opinion, is just there to give them a blood pressure so I can diurese them more aggressively. And Sarah, feel free to correct me on how you do your practice.
So I completely agree with Jamie. I would just rephrase the premise of the question a little bit, which is we're really trying to de-emphasize treating the class because, and really emphasizing treating the proteinuria.
Got it.
So if someone's really nephrotic and has a lot of proteinuria, they still might have on biopsy a class 4. But if they have a lot of proteinuria, then that's when I reach for that multi-targeted therapy. And like Jamie, I use TAC. Now, the context in which I don't use TAC is if someone's hypertensive or has a lot of renal insufficiency. But if they have relatively preserved renal insufficiency and a lot of proteinuria, regardless of what that biopsy shows, I'm going to use TAC with MMF. And I do it exactly like Jamie said, which I use it for short periods of time until the MMF kicks in or something else kicks in, like the OB kicks in or whatever other agent I'm using, just to diurese them, control the proteinuria, and use it for the shortest period of time. And the idea of having someone on a calcineurin for 2 years seems completely illogical to me to control their proteinuria. I would want them on it, 6 months. For the, and get it off by then. My goal is to have it off by 1 year and to have their proteinuria controlled with another agent. Because if I'm controlling their proteinuria with a calcineurin, I don't know what's happening immunologically. And just clinically, we know that when we take them off their calcineurin, their proteinuria comes back, which makes me think that their activity in their biopsy is high.
Thank you, Sarah.
So I had to step away for a second. I don't know if you addressed this, Jamie, but when you guys use tacrolimus, do you give set dosing or do you target low levels like 3 to 5? I was just curious of what your practice is.
It kind of depends more for my end. It's more based on symptoms. So if I generally try to get them close to the 5 to 7 range if they're pretty proteinuric. If it's I'm just using it to make their life a little bit more tolerable in the sense of edema wise, then I'll just go for a detectable level, so 3. But I always target somewhere in the 3 to 7 range.
Nice. Thanks. That was a great talk, Jamie.
Thank you.
Any other questions for Jamie? Thanks, Jamie.
Yeah,
Really very nice
thank you.
review. Appreciate it. Have a good day.
You too. Thank you.
Thank you.